So, give us a second.
Hi, good evening, everyone. So it's Selena, Pertika, and we have Syrian. If everyone is happy, just turning on their cameras, that would be great. For those who are attending, my name is Hassan. I'm one of the emergency medicine trainees at Broomfield Hospital, which is one of the hospitals of Mid and South Essex NHS Trust. I've been working in emergency medicine for the last 7 years nearly. I finished my master's in trauma sciences at Queen Mary University of London three years ago. And I've done my membership of the Royal College of Emergency Medicine 5 years ago. And today my session is going to be about the sudden onset headaches, which is going to cover most of the headache presentations to the ED. I'm not sure if Pratika and Syrian are there.
Yeah, I'm here.
Yeah, perfect. Fine. If everyone is happy turning on the cameras, that would be fine because it's just few of us. If any reason you can't turn on the cameras, just yeah, feel free to unmute yourself at any point and speak if you need to. And if everyone can just join the Kahoot, either by scanning the QR code or typing in the PIN. It's going to be a quite interactive session, so I need you all to participate.
Meanwhile, I think, I don't know if Syrian's having some technical issues, but would it be okay if it's just me and Pratika in this case?
Fine, it's fine. So it's you who joined at the moment, isn't it,
Yes,
Selena?
Yes.
Yeah, I joined as well.
You did. I can only see one participant so far. Selena, I think you
okay.
were. Yeah,
Hang on, wait.
I'll kick you out.
Wait,
If you can join
again, sorry.
No, it's fine.
Perfect. There we go.
Okay. Fine. So over the next hour, we are going to mainly cover the different presentations of headache and ED and the presentation and management of stroke and thunderclap headaches, and highlight the importance of using different algorithms and scores in ED and how that would make things easier for everyone, particularly in the chaotic environment of the emergency department. So the setting, I just need you to imagine that you are an F2 student and F2 doctor, I'm sorry, you're not a student anymore. And this is your first shift in ED. Unfortunately, it's going to be a night shift. And again, unfortunately, it's a small district general hospital, understaffed, and you haven't had your formal induction yet. But for staffing issues, you were asked to cover the night shift. You are supported with seniors. They are present to help you. You are not supposed to make any clinical decision, any final clinical decision on your own. However, you're supposed to take proper history, proper examination, and formulate your own plan, and then discuss it with one of your seniors. At the moment, there is only one consultant, 2 senior registrars, and the lucky you. And the consultant asked you to cover the minors and pediatric injuries at the moment until he can free one of the registrars from resus. They have got 2 trauma calls and 2 cardiac arrests running in resus at the moment. So no one is really able to go with you straight away. Luckily, there is one of the senior sisters in minors, and she's really willing to help. She has been in the hospital for 20 years. She knows how all the referrals can go on, and she's going to support you until one of the registrars is available. And if you haven't worked in ED before, this is how it looks like if you work in an understaffed hospital, which is the situation in every single hospital now. And especially if you go to minors in a very busy night, this would be exactly the case. Okay, so your first patient is a 78-year-old male who tripped and hit his head against the curb. He has an isolated head injury, and the C-spine was cleared by one of the registrars at the triage, so you don't need to worry about the neck. You just need to deal with the head at the moment. And he has got a 5 centimeter head laceration with active bleeding. So to start with, we have a multi-selection question. What would be the symptoms that you need to inquire about post-injury in this gentleman? It's more than one answer. Okay. Fine. So who chose? There is only one person who chose one episode, more than one episode of vomiting. If just feel free to explain why you chose this one, why particularly more than one episode.
I was just assuming it was either one or more than one. I mean, purely because, I mean, it would, how to put this? Like if someone hits you on the head hard enough, then I was thinking if it's on the nose, then it could olfactory and then it affects the brainstem. That's kind of what I was going for, really.
Fair enough. So you are concerned about vomiting. We can't simply say that. All right, we'll find out in a minute why particularly more than one. Why, if the patient just told you it's one episode, why you can simply put this aside and not get concerned about it. But if it's more than one episode, if he vomited 2 or 3 times, then yeah, would really get concerned. And current anticoagulant therapy, I think it goes without saying, if somebody's taking anticoagulant and they hit their head, the same amount of force, which going to just give me a head pump while I'm not on anticoagulants, is going to give him a bleed. He's more likely to bleed if he's on an anticoagulant. Is that clear for everyone? Perfect. I think we have someone, we have Tina joined us.
If possible.
Yes, hello.
Hi, Tina. Hi, good to see you. Are you able to join the Kahoot? If you type kahoot.it.
Yeah, okay, I will try.
Yeah, I just need you to participate as well. And we've got a few more. If everyone can just type in the pin down there, the game pin, 6127899, and just join with us because it's going to be a quite interactive session. Cool. So you need to ask about seizures, you need to ask about loss of consciousness. Actually, you need to ask about all these symptoms. And if none of them were present, you need to put that as negative parts of your history. Say, actually, there was no seizures, no vomiting, he's not on anticoagulants. So you are ruling all of that out. Fine. And we'll move on to the next question. Okay. I hope more people join as we go on. What other signs you need to look out for in this patient?
Sorry, do we know exactly where he was hit on the head or just in general, just anywhere on the head?
You mean anywhere in the head? Say that again, Selena.
Do you mean like, oh, sorry, never mind.
Say the question again. What do you mean?
I was just wondering, because you said his head hit the curb. Are we talking about this area? Because we said his C-spine was clean, or this, like, are we talking about like the calvaria? Like, where exactly on the head are we talking about?
Forehead or just on the temporoparietal region?
Okay.
Just that side? Cool. Fine. Yeah, I'm just trying to minimize every now and then, minimize the screen every now and then. So suspected skull fracture. How are you going to look out for suspected skull fracture in someone who has got a laceration? Any idea?
Maybe do a CT or an X-ray?
Well, I mean, you're just examining them at the moment. So there are some things you need to look out for. So before proceeding for a CT, there are some symptoms that would either push you towards doing a CT or actually push you away from doing a CT and reassure you. And there are some signs as well in your examination. So in this particular patient, if somebody has got a laceration, when you examine the laceration itself, some people, you can see a fracture sometimes. if it's a very deep laceration and the impact was a strong impact. So that's one method. The other method is basically just having a feel of the whole skull, making sure that it all feels the same. It's all hard everywhere. If it's less hard in one point, or if it's extremely tender in one point, then you would suspect a skull fracture. Part of your neuro assessment, you would check the pupils as well. So you need to find out if the pupils are equal, first of all, if they are reactive to light equally, each pupil direct and consensual, and if they are reactive to accommodation as well. It's part of your neuro assessment. And then the hemotympanum, there is no, in any head injury patient, the examination is not finished until you examine the ears as well. And finally, confusion at 2 hours post-injury, because it's if somebody is confused straight away after the head impact, that's very expected and can be very normal. It can be due to concussion. But if they are still confused 2 hours post-injury, this is not very reassuring. They need a scan at this point. And the reason I mentioned all of these, to be honest, is because they are all part of the NICE head injury guidance. There's one more question, and then we'll just review all the guidance. So what would be the first steps of managing this patient in ED? So you examine them, you have got your history, and you have asked about particular symptoms which are part of the NICE guidance. So definitely you're going to manage the wound, particularly it's an actively bleeding wound. So you need to stop the bleeding at the moment. And we said already, as you have a look in the wound, you make sure there is no fracture at the moment or so on. And then you would need to request a CT as per the NICE guidance. Is everyone aware of the NICE guidance? Have you ever been across these regarding the head injury? So Selena is nodding. Anyone else? Perkita? Tina? Okay. Admit for further observation. It's a bit too early for this one. We don't know yet what's going with them. I mean, they might have a very large bleed. They might need admission under the neurosurgical team. They might need referral to another hospital. So this one is a bit too early. It's not one of the first steps. Discharge with antibiotics and head injury advice is not a very wise decision, to be honest. Fine. So you decide to do a CT for this patient. You run that with your consultant, and the consultant is happy with it. So the patient gets the CT, and we will have a quick look on the CT in a minute. Can everyone see this clearly? Okay. So this is the NICE guidance for adults with head injury. This is an algorithm of a flow chart, actually. How would you proceed with each patient? So I've got seven questions to answer early on. They are risk factors. So if the GCS was below 13 on initial assessment, and by initial assessment, it's the assessment at any point before 2 hours after the head injury. So if the patient had the head injury and presented to the A&E within 30 minutes or so on, this would be considered the initial assessment. If at 2 hours after injury, it's less than 15, so confusion would count. Confusion would be a GCS of 14. If at 2 hours post-injury, GCS is less than 15, then you would do a CT. Any of them would just be yes, and then a CT within 1 hour. If there is a suspected open or depressed skull fracture, we know now how to look out for these. Any signs of basal skull fracture? We mentioned already hemotympanum, because it's one of the signs that people forget to look out for. If you don't examine the ear, you would never know that there is a hemotympanum. What are the other signs of skull base fracture that you know?
Raccoon eyes.
Raccoon eyes. Anyone else? Anything else you'd know, Selena?
Potentially, like I'm just thinking, like tenderness around the mastoid process.
Yeah, tenderness or more of bruising, I'd say, would be what is it called? Battle sign.
Oh yeah, battle sign. Yep.
So battle sign raccoon eyes, hemotympanum, and if there is a rupture of the tympanic membrane, rupture eardrum, you might have actually CSF leakage or blood leaking out of the ear. All right, and the nose, would you be able to tell if somebody's having a basal skull fracture by the nose?
Not really, no.
CSF leakage as well from the nose? CSF rhinorrhea or CSF otorrhea? So if CSF is leaking from the nose or you're having persistent bleeding from the nose, then you would consider a basal skull fracture. If you just imagine that in the anatomy, it's basically, this is the base of the skull just on top. So if there is a basal skull fracture, you can have CSF rhinorrhea or you can have continuous bleeding. However, if this is the case, if you can see blood coming out of the nose, ideally you should have a look because it might be an injury within the nose itself rather than an injury from the base of the skull. And if there is a seizure, if there is any focal neurology, and by that we mean any focal weakness, if there is weakness on one side, because if there is a bleeding, let's say affecting, if there is bleeding collecting on the right side, then it might affect, it might give you a left-sided weakness at one point. If the patient is behaving abnormally, you can put that as part of the focal neurological deficits. And if there is more than one episode of vomiting since head injury, if any of these is present or if more than one, then you would do a CT straight away. If it's only one episode of vomiting, you don't need to be concerned at the moment. You would, if the patient is completely fine and there is no other risk factors of the aforementioned ones or the ones I'm about to speak about, then you can safely discharge the patient home and give them a head injury advice leaflet and explain to them that if they vomit again, please come back to us. We'll need to reassess you. We might need to consider a CT at this point. Fine. So if there is, if you take any of these, then you would do a CT straight away. If there is none of these, then you need to ask yourself another question. Is this patient on anticoagulant at the moment? And by anticoagulant, what is the most famous anticoagulant you know?
Warfarin or heparin.
All right, perfect. Any other ones? Are you aware of the new oral anticoagulants?
Yeah, rivaroxaban.
Perfect.
No, and dabigatran.
Perfect. And there is apixaban as well. So the dabigatran is the factor 2. So it's bi, it's 2, factor 2 inhibitor, and rivaroxaban XA. So any XA, rivaroxaban and apixaban, they are activated factor 10 inhibitors. So these are called the direct oral anticoagulants, DOACs or NOACs, new oral anticoagulants or direct oral anticoagulants. And that's why this, if somebody has seen that algorithm before 2019, it was only current warfarin treatment. Now it's anticoagulant because people are more dependent on these in the last couple of years. Warfarin is just regressing now. Fine. So if your patient is on anticoagulant, again, it goes without saying they will need a CT. In the guidance, it says within 8 hours. But in real life, it doesn't really matter. The moment the patient presents, they need the CT. Is that clear? I know it looks complicated, but believe me, once you apply it a couple of times with any of your patients, it would be extremely simple and it will be printed in your mind. So you just need to go through it a couple of times. The good thing about the algorithm and that you can easily Google it each time before you go and see a head injury patient, and then you can apply all of that on your patient. You know the symptoms you're going to ask for, you know the signs you are going to look out for, and that's it. It's extremely simple. Fine. So your patient, let's say your patient is not on anticoagulant, then you need to ask yourself another question. Has your patient had loss of consciousness or amnesia since the head injury? If no, then there is no further imaging required and you can safely discharge them. If yes, again, you need to go through a very small checklist this time. So you need to ask yourself, is there age 65 or more? Is there a history of bleeding or clotting? Was it a dangerous mechanism of injury? Or there is more than 30 minutes of retrograde amnesia, so they can't remember events before the injury, like for 30 minutes before the injury. They should remember that because it's very recent. If they can't remember it, this is concerning. If yes for any of them, scan the patient. If no, no further scanning. So once you go through that a couple of times, it would be super easy, to be honest. It's just, it looks complicated, but it's not. Fine. So this is how you're going to treat your head injury patient for now. this is the same again. Fine. So that's your CT after the consultant approval. And what can you see? Okay. So it's not a subdural, not a subdural. Yeah, I've got 2 question marks. Fine, that's fine. It's an epidural one. So congratulations for the one said epidural. Who said epidural? Just out of interest, because they
It was
need
me.
Tina. Sorry. Who was it?
Tina.
Yeah.
Yes, it's me.
Yeah, Tina, can you explain to us, please, why is it an epidural and not a subdural?
Because it has a shape like a lens.
Yeah.
So that's why I was thinking about epidural bleeding.
Perfect. So it has a shape like a lens. It's a biconvex shape, isn't it? And why do you think it has got a shape like a lens? Any idea?
Because the dura is connected to the skull, so it's holding it. So I don't know how to explain.
No, you're right. You're right. I totally understand you. It's what you need. You mean to say is that the dura is sort of tethered here and here, connected to the skull at these points. It's more of compartments rather than a one large space. Is that what you mean?
Yeah. Yes. This is what I mean.
Okay. Is everyone happy with this concept? So that's why you get the biconvex shape rather than a lunar shape. If it's a lunar shape, then it's more likely to be a subdural. If it goes down with the sulci and the gyri, then it's more likely to be a subarachnoid. If it's an epidural or an extradural, just outside of the dura, then it would be between the dura and the bone. And the dura is tethered at these points. It's fixed at these points, which are supposed to be the fissures in the bone. So if the dura is fixed here and here, you'll only have a collection of blood in this point. Is that clear? Brilliant. Well done. Fine. And one more question with this patient. What would be the definitive management at this point? Just feel free to answer anything. It's not an actual evaluation. It's just a game. So even if you answer incorrectly, that's fine. It's all part of the learning process. Fine. So fondaparinux is an anticoagulant. We don't give fondaparinux for someone who's bleeding. Close monitoring is part of the management, but it's not the definitive management. It's not going to cure him. Stroke team, they're not going to help. Yeah, they might be nice to you on the phone, but they're not going to help. Neurosurgery is the right answer. Yeah, neurosurgery should be involved, and then they would put a plan with you. If you have neurosurgical team in your hospital, they will take the patient. If not, you'll need to refer the patient somewhere else or keep them under the general surgical team care until they get better. Most of these patients are managed conservatively. They don't need surgical intervention. Unless the collection is massive and it's causing increased intracranial pressure. At this point, they will need to evacuate the hematoma, but most of these patients are managed conservatively. So well done, it's neurosurgery. Cool. Fine, so well done. You did really well with your first case. And now the sister is asking you to see the second patient. who is a 59-year-old female with a background of hypertension, type 2 diabetes, COPD. She had 2 attacks of transient ischemia, 2 TIAs in the past. We are all aware of the TIAs. Transient ischemic attack in the brain. It's like a stroke-like picture, but for a brief period of time. Cool. And then for the last 2 hours, she has been complaining of left-sided weakness and dysarthria. The stroke nurse at the moment, usually what happens is if someone is presenting with a stroke-like symptoms, they would go directly to the stroke team. But as we mentioned, you're a bit unlucky tonight. It's your first night and the stroke team is super busy at the moment. They have a patient and they are about to start thrombolysis and rhesus. So they are not really happy to see the patient at the moment. Your senior nurse did a VBG for you because she knows very well that any electrolyte imbalance can present with a picture similar to stroke or can present with weakness, usually general weakness, but she has done that for you. And particularly for the glucose, because hypoglycemia, again, can present with confusion and unilateral weakness. It's one of the stroke mimics. So the nurse has did the VBG for you, and the VBG is unremarkable and the blood glucose is fine. So it's not a case. So the first question is going to be a multi-select again. Which score you are going to use to recognize a stroke or a TIA in the emergency department, if you ever heard of any of them? Okay, so we have 2 answers for the Rosier score. Who chose the Rosier score?
I did, but it was just a tip. I don't know nothing about that.
Okay, no worries. And who else? Somebody did. Yeah,
I said it. I did.
I'm Mustafa. Oh, yeah. So do you know the Rosier score yourself?
No, not really. I kind of guessed.
Okay, fine, no problem. Don't worry about that. So the Abcd2 score. So the scores I'm mentioning, they are not super complicated. I mean, if we use them literally every day. The Abcd2 score is a score used for the TIA. It was used until, I believe, a couple of years ago when the NICE guidance was updated and it sort of advised against its use. It would tell you whether the patient is having a TIA or not, and it would tell you how severe is the TIA and how quick the patients need to be seen. Now it's more of an obsolete score. It's not being used, to be honest. If you suspect a TIA, a transient ischemic attack, stroke-like symptoms that resolve after like 30 minutes or an hour or so, that completely resolve, then this patient, all these patients will need to be seen within 24 hours. So this score is now obsolete. Nobody's using it, at least within the NHS, as per the new NICE guidance. Chalice rule is a rule for children for head injury. Again, we don't usually use this one. We depend on the NICE guidance for the head injury in pediatrics. Ottawa rule, there are so many Ottawa rules. There is Ottawa rule for ankle injury and Ottawa rule for knee and Ottawa rule for subarachnoid hemorrhage, but there is none for stroke as far as I'm aware. So the Rosier score is the recognition of stroke in emergency room. It's an acronym, just the first letter of the whole name. And basically it would give, so if it's all 0, then anything of 0 or below, it rules out a stroke. Anything more than 0, if it's 1 or more, it doesn't really matter. If it's 1 or 5, it doesn't really matter. If it's more than 0, you would say it's a stroke at this point. So if we look closely, so loss of consciousness or syncope, if it's not present, you get a 0. However, if it's present, you get a minus or a -1. If there are seizures, you get a -1 as well. So this means that basically the loss of consciousness or seizures are against having a stroke. If you find out in the history that this patient had seizure and now he's having paralysis, then it's more likely to be a post-ictal paralysis. Todd's paralysis. Have you ever heard of that?
What kind of paralysis?
Post-ictal, post-seizure weakness.
Yeah.
It used to be called Todd's paralysis. I'm not sure whether is everyone using the name now or not. However, the important bit of the story is that if someone had a seizure or loss of, sorry about the dog barking. Is it too loud?
It's manageable. It's okay.
Okay, fine. Yeah, if there is loss of consciousness or seizure, then this is against having a stroke. Your patient would get a -1 at this point, so it doesn't really point to a stroke. However, if there is weakness in the face, arm, or leg, or speech disturbance or visual disturbance, any of them or all of them would point towards a stroke. In the layman's terms, all the people now know the FAST. FAST is an acronym for face, arm, speech, and time. So the people are aware of this now. So if they see any facial weakness, any arm or leg weakness, or any speech disturbance, they would call the ambulance immediately. So the T is for the time. Fine. So it's a score which is really good if you use it. Again, all of these scores are from the MD Calc app. Everyone is using it, to be honest. What would be your next steps in managing this patient? Okay, so A2E assessment and non-enhanced CT brain are the right ones. So your next steps of management. So 2 people said MRI brain and wait for the stroke team. To be honest, they are right answers, but the thing with A&E is that it's a low resource environment. You don't have the luxury of resources. You don't have the luxury of time. So you don't have the luxury of resources. You don't have access to MRI in the vast majority, even most of the EDs in the UK. And even if you do, you need to book a slot, even for an emergency MRI. And it should be a consultant level. Usually none of the junior doctors arrange MRI. So this one is a bit delayed. It doesn't happen straight away. It doesn't happen from A&E, and it takes a lot of time. In A&E, you have a 4-hour target. So you need, within the 4 hours, you need actually to put your patient somewhere, have a formal diagnosis, have a formal plan. Either send them home, bring them in one of the clinics, or keep them in the hospital under one of the teams, or send them home with completely reassurance they are perfectly fine. So MRI is not going to happen within 4 hours. So it's not one of your next steps of management. Wait for a formal assessment by stroke team. Again, it's not ideal, to be honest, because your patient started having the symptoms 2 hours ago, and time is of utmost importance at this point. So you need to be extremely quick. You need to find out what's going on with your patient. So I'd not wait for the stroke team. A2A assessment is really important, because if the GCS is progressively getting worse, then at one point you'll need to protect the airway. The patient will not be able to protect their own airway. CT brain, yes, that's definitely, you can get it done. Most of the hospitals have what's called the CT stroke protocol. So it doesn't even need a doctor from the radiology department. It doesn't really need a radiologist to accept or vet the scan. The radiographers would do it straight away, again, just to save time. Fine. So we agree to do this, and your CT happens, and the CT report is basically confirming early ischemic stroke, ruling out any hemorrhage. So there is no hemorrhage. and suggesting thrombolysis if it's not contraindicated and if it's within the licensed time window. So basically, the reason we do a CT in a suspected stroke, you're not going to see the early signs of ischemic stroke all the time. It needs one of the radiologists actually to report it, and it needs a qualified radiologist. Extremely hard for junior doctors to pick them up. The stroke team would be able to pick up the early ischemic stroke signs on a CT. But the main reason, to be honest, is basically to rule out any intracranial hemorrhage. And the reason is, if the patient is having signs of stroke, you need to make sure there is no hemorrhage. And this points more towards ischemic stroke rather than hemorrhagic stroke. And at this point, you would consider thrombolysis in this case. Does it make sense? Cool. Is everyone, because I can't see the rest of you, I can only see Selena. So if there is anything of what I'm saying doesn't make sense or not clear, just feel free to speak up, please.
Also feel free to use the chat if you don't want to do that.
Yeah, I can't see the chat box. I can only see your names and so on. But
I've
if there's
got a
anything-
question. If
Yeah, go on.
if it was a hemorrhagic stroke, what would the if not, it wouldn't be thrombolysis, would it?
That's correct.
What would it be?
You're not going to thrombolyze it because it's hemorrhage.
Yeah.
What would it be? That's your question, isn't it?
Yeah.
All right. So if you wait a little bit, we'll find out together what would it be.
Okay.
You're right, Mustafa. All right. Perfect. Cool. Just a quick true or false question about thrombolysis. Okay, so can someone from those who selected false just explain to me why false?
Isn't it 12 hours? Or
No, it's shorter than that.
or is it 4 hours? One of the. is it 4
Yeah,
hours?
it's 4.5 hours. You're nearly there. It's 4.5 hours. So again, it's all of that. I went through the nice guidance just before preparing all of that, just to make sure nothing has changed because they keep updating it. So it has been 4.5 hours for a very long time, and it's 4.5 hours actually. So your patient whose symptoms started 2 hours before arriving to the A&E has got less than 2.5 hours to thrombolyze her. That's why time is really important. So if you waited for MRI, it's likely going to happen. So the quickest it can happen in a hospital who has a 24-hour service for MRI, it's going to be within 2 hours or so. So you wasted her window at this point. And the CT can just provide as much information as you need. Basically, you need the CT at this point just to make sure it's not hemorrhagic, and then you can deal with it later. Fine, so it's 4.5 hours. Just remember this because it can be life-saving. And one more question. So you diagnose the stroke now. How are you going to quantify the severity? Are you aware of any score that can quantify the severity? If you never heard of them, just don't worry. The reason I'm mentioning them is just for you to be aware that they are present. Nobody's supposed to memorize them all, but just know that there is a score. Cool. Okay, so the Rosier score, we already, I'm happy that no one picked this one. So the Rosier is for recognition in A&E, in the ER or the ED or A&E. So it's not definitely this one. CHAD, so CHADS and CHADS VASC score, both of them are for quantifying the risk of stroke or ischemic events in the presence of AF. So you use that with AF patients. CHADS is the first score, and then they developed CHAD VASC. So everyone is using the CHAD VASC score. each letter stands for something. And again, if you download the app MD Calc, everything is on it. You don't need to memorize any scores at all. The NIHSS is the Nih Stroke Scale. And this score actually is used by all the stroke nurses to quantify the severity of a stroke, of a diagnosed stroke. It would let you know if the stroke, so it's a very long checklist, and you just tick the boxes actually and score each element of it. So if the score is less than 4, some sources say less than 6, then it carries a favorable prognosis for the patient. And if it's more than, I believe, 24, then it would carry a very poor prognosis for the patient. And that's it. You just need to be aware of the presence of the score itself. And if you have time in the ED, ideally you should document it as well, if you have time, which is not the case. So this is the score. This is the NIH Stroke Scale. It's a very long one. It takes a lot of time. Part of it are questions, level of consciousness, and then you need to do proper neurological examination. So it really takes some time. It's not a quick one. You don't need to memorize it, just be aware of its presence. So well done. Your second patient now is with the stroke nurses, and they are happy to take over from you. They're going to start the thrombolysis now. Make sure the patient hasn't got any contraindications or so on, and they're taking over from you. And the consultant is really pleased with your management so far. So the third case, you were asked to see a baby, and nobody is pleased to deal with a baby on their first shift. It's quite intimidating to deal with kids. So you have got an 11-month boy who had an accidental head injury. He was very irritable at home. That's what you read on the triage notes. And he has got a 3-centimeter boggy swelling on the forehead. He vomited 2 times, as mom mentioned, at home. There is no suspicion of non-accidental injury, as the nurses mentioned. And otherwise, the child is extremely well in himself. Sorry, it's a typo here. And he was very active in the waiting room. He was playing with the other kids, and he was perfectly fine. So let's move on. Another multi-select question. What do you need to cover in the history taking this time? Okay, so let's start with the exact time of injury. So exact time of injury, why all of you, I think I have 4 people on the Kahoot, so all of you nearly chose the exact time of injury. Why do you think this is important?
Let's say worst case scenario, it is a hematoma and irritability could be a sign of it, then we need to know how much time has passed to see if there is any damage or if there's going to be any long-standing damage depending on when the injury happened.
Okay. Yeah. Any other idea?
If it's been a while, then you have to act quick.
I agree. Yeah, but the nurses seem at ease. So if you ever worked with the pediatric nurses, they would know very well if the child is unwell. If they really urge you to see someone, then yeah, they are unwell, even if they look fine to you. So the nurses seemed at ease, to be honest. Okay, so the exact time of injury, you are partly correct, Selena. So you need the exact time of injury because it's going to help your clinical judgment in a minute. But yeah, ideally there shouldn't be damage at the moment, because if there is brain damage or so, the child would have more severe symptoms, would be more unwell and so on. But in this particular case, ideally, no, most of the children are like that. They would be irritable at home, and when they arrive into the emergency department, they will just play around and forget about it. The exact time of injury is important for another aspect, which might be out of the scope of this session of the headaches and so on, but it's related to the non-accidental injury. So if you have a child with a boggy swelling, you are all aware of non-accidental injury? Non-accidental injury is child abuse in other terms. So accidental injury is an accident. A child fell, all children fall and trip and so on. But if the child is being physically abused or neglected or so on, all of that fall under the non-accidental injury. And believe me, it's far more important actually than the medical knowledge at some time to be aware of the non-accidental injury. So you need to keep that in mind whenever you are assessing a child. It's part of the safeguarding and so on. And with adults, you need to be aware of the safeguarding concerns. Fine. So exact time of injury is important because if it was a child abuse or non-accidental injury in other terms, the child would present very late after that. So when you ask the mom or so on, she might say, yeah, he hit his head 5 days ago and I brought him today. Then this is really concerning. You need to assess this child for other injuries and you need to raise a concern with one of your seniors. That's why exact time of injury is important. It's related to the head injury itself, and we'll discover that in a minute. Vomiting discrete or back-to-back, because in the NICE guidance, again, you would scan a child's head if they vomited more than, if they vomited 3 times or more, and they particularly say discrete. Because in kids, they vomit a lot, especially with pain. So if they are in pain for any other reason, they can just vomit. And back to back, if they vomit and then catch their breath and vomit again, this is considered one episode rather than 2 episodes. So that's why it's extremely important to find out from the mom. She said he vomited 2 times, but if you ask her very clearly, was it just back to back, or was there a gap of few minutes in between? He was fine and so on. If she says, yeah, there is a gap, then it would be discrete. Each of them would count as a separate episode. Diarrhea post-injury is not really important. No, he might have diarrhea before the injury itself, but it's not related to the head injury as far as I'm aware. And mechanism of injury, yes, definitely that's important because again, it will tell you whether it was a dangerous mechanism or not. It goes without saying. Fine. Can everyone see that? Is it clear? So again, you need to go through several risk factors. Any suspicion of non-accidental injury? If yes, scan. Any post-traumatic seizure? Just make sure there is no history of epilepsy this time, because if there is history of epilepsy, then it can be not related to the head injury itself, can be more related to the epilepsy rather than head injury at this point, if the child has a seizure after the head injury, if it makes sense. And then on initial assessment, for anyone above 1 year, if the GCS is less than 14, you would scan them. If someone is less than 1 year and the GCS is less than 15, you would scan them. At 2 hours, if the GCS is less than 15, you would scan them again. Any suspected open or depressed skull injury or tense fontanelle, usually you can feel the anterior fontanelle in most of the kids. Posterior one closes very quickly, so it would be less likely to feel it. If it's very tense, bulgy, then you would scan them. This means that there is increased intracranial pressure. Any sign of skull base fracture, we discussed that already. Hemotympanum, panda eyes, CSF leakage from the ear and nose, and Battle sign. We mentioned all of that in the adult. Focal neurology, and this one is particularly important because our child is less than 1 year. He was 11 months. So any bruising, swelling, or laceration of more than 5 centimeters, he had just a 3 centimeter bruising. So that's why examination and documentation is particularly important. So you need to document that it was less than 5, and you need to draw actually just a diagram of the head and point where the boggy swelling is. If any of these are present, then you would do the CT straight away. If none, you need to ask some more questions. Was there any loss of consciousness for more than 5 minutes? Was there any abnormal drowsiness? Was there any 3 or more discrete episodes of vomiting? And how was the mechanism of injury? Is there any amnesia, which is extremely difficult to elaborate in kids unless they are verbal? And just a hint, if you are examining a child, particularly for any injury and head injury, just ask them what happened. Children are very, very talkative and always like to tell other people what happened, especially when they feel that the focus is on them. So they will tell you particularly what happened, how did they have the fall and so on. So it would tell you that they don't have a retrograde amnesia, they remember very well. And again, it would reassure you that it's not child abuse or non-accidental injury, because if they tell you, yes, I fell and hit my head, then this is very reassuring. So if there is none of these factors, then you would check if they are on anticoagulant or not. If not, no imaging. If yes, imaging. If there is only one factor, then you need to observe them for a minimum of 4 hours post-injury. And that's why the exact time of injury is very important. That's why I document it as well. So the injury happened at 5 p.m., then I need to observe them until 9 p.m. and that's it. If after 4 hours, the GCS is 15 and there is no further vomiting or no further episodes of abnormal drowsiness, you can safely discharge them. If there is more than one factor of these risk factors, just scan them, don't wait. All right, it looks complicated, it looks super busy, I totally agree. That's how it looked to me the first time I saw it, but later on, once you practice and apply that to children, it gets very easy. And it helps you actually to cover all the points and make sure you didn't forget any part of it. So the algorithm is really helpful. And this is the Glasgow Coma Scale for kids. It's a bit different, particularly in the verbal part. So in anyone up to 5 years, because they might not be verbal. So that if they are alert, babbling, cooing, making sounds, then that would be 5. If they are less than usual, then it would be 4, and so on. So it's really helpful to actually have a quick look on the pediatric GCS, because it's different. You wouldn't be able to tell if a child is confused or not. It's really difficult. You need to be aware of that, and you need to ask the parents, always involve the parents. Is that normal for your child or not? Fine. So back to our kid. So the 2 episodes of vomiting were actually back to back, and the mom told you that when you asked her, when you explained to her that it's really important, she said, yeah, they are back to back. So we considered this as 1 episode. The baby had no signs or symptoms necessitating CT brain. And while you were planning to discharge the baby, after discussion with your consultant and approval of your plan, he vomited 1 more time. And in a couple of minutes, he was back to normal and running around the room. So the next question would be, for double points. All right, brilliant. Okay. So why do you think he needs urgent CT head?
Well, like you mentioned earlier, usually, I know it's in adults, but when anyone has more than 1 vomiting episode.
Yes, that's for adults.
Yeah, maybe it's for kids too.
No, we have just been through that. So in kids, it's different. If it's 3 or more episodes, 3 or more discrete episodes of vomiting, then this is the point you would consider doing a CT head. Is that clear? I'm not sure whether it's part of the media here. No, I didn't put it here. What we can do, if I open a new tab, you can all see that, isn't it? Okay, brilliant. No, not this one. This one. So it was one of these parts actually. If there's 3 or more discrete episodes of vomiting here. So guess what? If it's only, if it's only If it's only vomiting, then you just observe them. And if there is no further vomiting, you would send them home. But let's say if it was vomiting and abnormal drowsiness, then it's more than one factor. Then at this point, you would scan them. All right. So this child doesn't need a CT. He had 2 episodes back to back. And I just mentioned clearly that this would be considered. He had, I'm sorry, he vomited 2 times back to back. So this would be considered as 1 episode. They need to be discrete. There need to be a gap between them. And back to back is that he pukes and then he just catches his breath and then pukes again. So this is 1 episode. The reason I'm mentioning that because it's really important to find out in your history taking, and it confuses everyone, and you need to document that clearly as well. Nobody chose this one, so this is the right answer. Actually, you need to continue with your plan. Reassure the mom, explain to her very clearly that if he vomits one more time to bring him back, but just 2 episodes is not really concerning, and your consultant approves the plan as well. No need to refer to the neurosurgery. Nothing wrong with him. Even if you're going to scan him, this is not the time to refer him to neurosurgery. Once you get the scan, then you can do that. Head injury advice and leaflet, yes, definitely. And you need to explain it verbally as we have been talking now. You need to make sure that the mom is completely happy with it, and you need to document as well that mom is happy with the verbal advice you gave, and the leaflet should have hospital phone numbers and so on to call if she has any concern or wants further advice. The leaflet should have the same verbal advice you're going to tell her. Fine, so you discharge this child because he only vomited 2 discrete times and not 3, and he hasn't got any other concerning signs or symptoms. Cool, so well done. You are in the mid of your shift now, and you move on to case 4, who is a 55-year-old gentleman. He has got atrial fibrillation. He takes the Abcd2 pan. The one we mentioned is one of the NOACs or the DOACs. He has got migraine. He has hypertension as well. Unfortunately, he ran out of his antihypertensives and he couldn't get a resupply of his prescription. He has been having ongoing confusion and headache for the last 3 hours. The family are extremely concerned. He's not his usual self. He has normal observations, normal vital signs in other terms. And again, your nurse has done a VBG. It shows a normal blood glucose and normal electrolytes. So in neuro assessment, he opens eyes spontaneously. He speaks inappropriate words, and he is dysarthric. He obeys commands. He has, Perla is pupils equal and reactive to light and accommodation. And pupils are 3 millimeters. So they are equal, 3 millimeters each, reacting to light and accommodation. You noted a dysdiadochokinesia, and you noted some ataxic gait as well while he was walking into the room. The family told you that this is very abnormal to him. He doesn't usually walk like that. And the first question is, what is his GCS? He opens eyes spontaneously, inappropriate words, obeys commands. Okay. So it's inappropriate words. So this is abnormal. It can't be 15 by all means. So for the eyes, he would get, you are all aware of the GCS, a Glasgow Coma Scale.
Yeah.
All right, perfect. So he opens eyes spontaneously. He'll get a 4 for this one. So it's E, V, and M. We'll cover that in a minute. Let's just move on. He only lost 2 points actually. So it's E, V, and M, 4, 5, and 6, total of 15. He opens eyes spontaneously, so that's a 4. If it's less than usual, he loses 1. More abnormal, he loses another 1. No eye opening, he would get 1. There is no 0 here. Voice, he's not oriented, he's not confused. He's having inappropriate words, so he gets a 3. and motor, he obeys commands. That's how you assess that is dysdiadochokinesia. Otherwise, if he doesn't obey commands, you would never be able to assess that dysdiadochokinesia at all. So 4, 3, 7, and 6, 13. So the total is 13. And it's really important to document it as well, as we will find out. And your next question would be, how are you going to manage him? What's the next step? Only one step. Brilliant. Okay, so the majority chose a CT brain. Perfect. Admission under stroke team, again, they're going to be extremely nice to you over the phone, but they will say, no, he's not for us. There is no stroke symptoms at the moment. It can be a stroke, but let's get the CT first. And he's as well on anticoagulant. He's hypertensive. He ran out of antihypertensives, so it's pointing more towards something else. And they're not going to accept an admission straight away. At least get the CT first. It's all about planning ahead. It might be one of your a part of your plan, but it's not the next step. Reverse anticoagulant, we don't yet know what we are going to find in the CT. Refer to neurosurgery, no way. They will say no as well. Get the CT first. Fine, you get a CT, and this is what you see. You don't need to type very specific answers. Even a general answer would do. You don't need to mention the side, whether right or left. It doesn't really matter now. All right. Brilliant. Okay. So it's all of them are right. So it's a bleed. This one is a bleed. Which part of the brain is that? Any idea?
It's on the right side.
It's on the right side. That's correct.
Is it part of the occipital area, like the occipital part?
Perfect. And so the occipital is basically part of the skull, but just underneath, what would that be? So it's the lower part of the brain.
Cerebellum?
Cerebellum, isn't it? Yes, well done, Mustafa. So on the right side, yes, because the CT is a mirror image, as if you are looking at the patient from their legs, from the end of the bed. So right is going to be left, if that makes sense. So this is the right side. And right cerebellar hemorrhage. There's some edema as well. But yeah, that's it. So well done. And the next question is going to be, it's a multi-select. What would you do next? More than one answer are right. Just feel free to choose anything. It doesn't really matter. Okay. Fine. So you need to aim for a systolic blood pressure of 130 to 40. Yes, you need to control the blood pressure. Otherwise, the bleeding will just continue. It seems very reasonable. Involve anesthetics for intubation. Yes, I'm glad nobody chose this one. When would you involve anesthetics for intubation in this particular case? Any idea?
If the GCS is lower than 7 or no?
Yes, it's 7 or below. So that's how I remember it, Mustafa, because it's really confusing. So we have got a lot of numbers in medicine. So I always remember it below 8 intubate.
Okay.
It rhymes.
Okay.
So anything below 8, just intubate, because the patient would have a very low GCS and they will not be able to protect their own airway. So 7 or below, yes, I totally agree. You would involve anesthetics here, even if he seems to have a patent airway at the moment. Anyone knows what is idarucizumab or andexanate alpha? I see 3 people chose andexanate alpha.
Andexanate alpha is a antidote for anticoagulants.
Which anticoagulant? Any idea? It's the right answer. It's the one he's taking.
I'm not sure. Probably a factor 10 inhibitor.
Yeah, brilliant. I'm just pointing to it. XA.
Okay.
X is 10 in Latin. So that's what we mentioned earlier on. So Apixa ban. So it bans factor 10A. And Rivaroxa ban, it bans factor 10A as well. That's how the name is made. So andexanate, the reason I mentioned it, because it's a very novel drug. It has been just licensed very recently, I believe, by the end of 2020 or 2020, early 2021, if I'm not mistaken. It has been very recently licensed for use for apixaban and rivaroxaban reversal. Before that, we used to reverse it in other ways. There was no specific antidote. The idarucizumab has been there for, I think, maybe 7 years now. So the idarucizumab is the reversal agent for the dabigatran. So from all the DUOX or the NOACs, the new oral anticoagulants, we only had one reversal agent until very recently. This is here, the andexanate alpha. The andexanate alpha is one of the most expensive drugs you're going to use. The course of the full course you're going to use to reverse the apixaban or rivaroxaban will cost 15,000 sterling pounds. So it's very pricey. I haven't used it myself so far. But yeah, you just be aware of the name, because likely when you graduate and start working, it will be available and you might need to use it as well. Fine. So,
sorry, I got a question. Were we told that the patient was taking a apixaban or rivaroxaban?
yes.
Or which? Okay.
Yeah, I said that early on. It's my very first time to use the Kahoot, so I just realized that we can't go back.
Yeah.
I'm really sorry, but yeah, he was on apixaban.
Okay.
He's not here as well. Fine, he takes it for his AF. Cool. I know it's nearly an hour now, or even more, but if anyone would like to leave, just feel free. If anyone has got other commitments, but or if you all would like me to stop here, I'm more than happy to stop.
No, Can I have a question?
Perfect.
Sorry, who has got a question?
Me.
Yeah, go on.
Yeah, I'd like to ask why we are giving him the andexanate alpha if it's like antidotum for coagulants, because he's bleeding into brain.
Yes.
So wouldn't it cause more bleeding?
So it's an antidote, it's a reversal agent. That's how you are going to reverse the anticoagulant. Is that what's confusing you? Just tell me again.
Yeah, I got it now. Yeah.
Okay.
Thanks.
No worries. So the first step you would do is basically, let's say, because it happens all the time. So the patient trusts you as a doctor. So once he sees you, and if you don't tell them, please stop taking the anticoagulant now, he might have it in his bag and he's going to take it because it's due now, if it makes sense. So the first thing you would say, please don't take your anticoagulant. Please don't take your apixaban. We're going to give you something to reverse the effect of the apixaban, because you are bleeding in your brain, and this is very critical. So one of the steps as well is to tell them verbally and tell the family, anyone with them, that please don't take your apixaban. Particularly the patient is confused as well, so it's highly likely that they might take it. Is that clear?
Yes, thank you.
Perfect. Fine, one more true or false for double points as well. There is something called prothrombin complex concentrate, PCC. So if you don't have the andexanate alpha, can you give it in this case to reverse the apixaban effect? Just true or false? Has anyone heard of it? Fine. It's okay. You can just try your luck. Okay. So it's yes. So this is what we used to use before. So very simply, we said that the apixaban or the rivaroxaban, the somehow stop the effect of factor 10, activated factor 10. 10 in Latin is the X. So XA is activated factor 10. So they inhibit factor 10. They are direct inhibitors. So the PCC, the prothrombin complex concentrate, has got fresh factor 2, factor 9, and factor 10. And that's why when you give it, you are sort of replenishing the factor 10 stores in the body in very simple words. Does that make sense? And that's why we used to use it before the andexanate was licensed for use. The other thing you can use is fresh frozen plasma, but in our trust we used to use the prothrombin complex concentrate. I'm not entirely sure what they are using now because I'm currently doing anesthetics and ITU, so I'm not entirely sure whether if we have the andexanate in the hospital or not. So it's really worth finding out. But just be aware that if you don't have this, you can use PCC or fresh frozen plasma. It all depends on where you're going to work afterwards. So moving on. The fifth case is a 72-year-old gentleman with a background of hypertension, type 2 diabetes, arthritis, and he's known to have multiple mental health issues. He's very well known to the mental health services. And the triage nurse told you that she has seen this man multiple times with mental health issues. He is wearing sunglasses at 3 a.m. and he told the nurse that he had the worst headache ever today. It happened all of a sudden 7 hours ago, and the painkillers are not helping. And that's it. So just true or false, again for double points. Why do you think somebody would wear sunglasses at 3 a.m.?
Potentially photosensitivity to streetlights.
Yeah, maybe. Why not? Due to his mental health issues? It can be, isn't it? It can be, but again, we are not supposed to jump to conclusions, isn't it? We need to rule out any medical issues first. And someone who is having mental health issues for any reason, that doesn't prevent them from getting any medical conditions, isn't it? Brilliant. Fine. So this happens a lot, actually. It's not just for the case scenario. You'd see this multiple times. So he is having photosensitivity as well. Yeah, Tina is going up now. All right. Anyone knows what's thunderclap headache? Again, just type out what you think it could be. Yes, yeah, that's correct. So the thing is, thunderclap, it comes from thunder, actually. So it should be extremely quick. It should reach the maximum intensity in a very short period of time. So the maximum intensity would be, you're all aware of pain scores. Pain score between 0 and 10. 0 is no pain, 10 is the worst pain ever. And if the patient is a female who had children before, 10 out of 10 would be like giving birth. 10 out of 10 would be like having a very nasty fracture for someone. So it's really very, very subjective. In this particular case, you would ask, how bad is the pain now? Usually someone who is having that severe headache, it would be between 7 and 10. And by thunderclap, they would tell you that actually it reached the maximum intensity of, let's say, 9 within 10 seconds, 30 seconds, up to 1 minute. So the definition differs between multiple sources. I've read it reaching maximum severity in 1 second, reaching maximum severity in 30 seconds, or reaching maximum severity in less than 60 seconds. What I'd say, if it reaches maximum severity within less than 1 minute, yes, you can consider this a thunderclap headache. Is that clear now? Cool. So some thunderclap headache is actually usually points out to subarachnoid hemorrhage. There is a rule, an Ottawa subarachnoid hemorrhage rule. I find it particularly useful for someone who hasn't seen multiple subarachnoid hemorrhage cases before. Again, it's a very good rule to rule it out. It doesn't really rule it in. And some of the consultants don't really like it, but yeah, it had proven itself really good so far. So it basically applies for anyone above 15 having a new severe atraumatic, which is non-traumatic headache within the maximum intensity within 1 hour. You don't use it in someone who had previous neurological deficit, prior aneurysm, prior subarachnoid hemorrhage, or known to have brain tumors or chronic headache. And this is the rule. So if it's to rule it out, you need actually to have no for all of these questions. If it's yes for any of them, then you can't rule it out completely. So the age need to be 40 or more. If the age is 40 or more with thunderclap headache, with headache that reached its maximum intensity that quick, then you can't really rule it out. You need to do some other investigations to rule it out. So the Ottawa rule helps you to rule it out just by history taking and examination without doing any other investigations. So if the patient is 40 or more, having neck pain or stiffness, just pain at the top of the neck, because usually the thunderclap headache feels, the patient feels the headache in the occipital region. So if they have neck pain as well, then this is really concerning. You can't just rule it out by history and examination. Loss of consciousness, onset during exertion, and this is particularly because during exertion, your blood pressure usually rises. And if someone is having a aneurysm in their brain, it's more susceptible to just rupture with any sudden increase in the blood pressure. That's why they mentioned this point here. And thunderclap, again, the definition is different. So they say if it's peaking within just 1 second, it's not very realistic. Usually the thunderclap is described by the patients within like 10 seconds or so on. Limited neck flexion on examination. If any of these are present, you can't really rule it out just by history taking and examination. You need to do something else to rule it out with. Cool. The patient had a CT, and this is what you see. What do you think it is? Again, just feel free to type what it could be. Okay. So this is a non-enhanced CT scan, and by non-enhanced we mean just non-contrast CT. So definitely this is not a contrast. And arthritis, it's really difficult to see it on a CT. I'm not entirely sure actually what you would see in arthritis on a CT head. Up to my knowledge, you can't really see much. So this is basically white matter, which is not as dense as the skull. So it's less dense. So it's not calcification. This is blood, and blood which is not biconvex. So it's not an extradural, not lunar shape, crescentric shape. So it's not subdural as well. It's respecting the sulci and the gyri, and here you can see it just in the falx cerebri, which divides the right and left, separates the right and left cerebellum. cerebrum, sorry. So this is blood here and there. What would that be? Which kind of hemorrhage would that be? It's not extradural, yeah?
Subarachnoid?
Perfect, yeah, it's subarachnoid. So this is subarachnoid hemorrhage. So it's not an extradural, it's not a subdural. This is a subarachnoid. So again, this patient had a thunderclap headache. And as you mentioned, Selena had a photophobia or light sensitivity. That's why he's having his sunglasses at 3 a.m. It's not due to his mental health issues. And there is a bleed on the CT, which goes with the subarachnoid hemorrhage. So yes, it's true actually. If the patient presented in the first 6 hours after the onset of headache, a good quality CT and a good radiologist can safely rule out subarachnoid hemorrhage. This was a large study actually done on hundreds or thousands of patients, and that's what they found out, that within 6 hours, if the CT is negative, then you can safely rule it out. However, there was, I think there was a communication by the Royal College very recently that even though if you still have clinical suspicion, this patient will need to stay in the hospital. It might not be safe to discharge them, particularly if their symptoms are not resolving. But it's really worth knowing this important piece of information, because usually when you try discussing with the medical team or so on, if you'd like to admit a patient for further investigations with a negative CT scan early on, they would bring up that if a CT is negative within 6 hours, you can safely rule it out. Yes, that's correct. It's the study findings, but it doesn't happen all the time. And again, you're supported with a consultant most of the cases. So actually in all the cases, you are not supposed to make a final clinical decision on your own. So your consultant would guide you as well what to do with the patient and how to safely put them in the right place. Fine. We are nearly there. So what would be the management if the patient presented more than 6 hours? And so the patient presented 8 hours after the headache, let's say, after the onset of headache, and the CT is entirely unremarkable. What would you do now? Okay. So if a patient is having a thunderclap headache just sheds light directly on a subarachnoid hemorrhage. If someone is mentioning thunderclap, then it's subarachnoid until proven otherwise. Usually it's in the occipital region. They don't need referral to neurosurgery at the moment because they're not going to do much to them. There is no bleed that you can see. Unremarkable CT means a normal CT. So neurosurgery are not going to do anything with this patient because there is no bleed to treat. Discharge with oral morphine and codeine might not be very wise because he's still having symptoms. And again, the reason I mentioned the 6 hours because of the previous piece of information we mentioned that within 6 hours, a negative CT can rule out subarachnoid hemorrhage. But in this case, someone who presented after 6 hours, so the rule does not apply here, and their CT is normal, then at this point, you still need to strongly suspect a subarachnoid hemorrhage and admit them with the medical team, where they will get a lumbar puncture. It's a typo as well, sorry about that. Observing them for 2 or 4 hours in ED is not going to help, is not going to add much. What do you think the lumbar puncture would show in this case? And any idea? Someone with the bleeding in their subarachnoid space, and it's
Maybe liquorea.
Maybe.
Maybe.
Can you say that again? I didn't hear you.
Maybe liquorea, like blood in the liquor.
Yes, it would show blood actually. It's called, you said liquorea.
Yes, yes.
Okay, I didn't hear this term before, but it would show dansochromia, which is a tinge and a yellowish orange tinge of the CSF, which is what you are saying actually, Tina. Yes, it would be sort of, it's not going to be bloody, it's not going to be blood stained, but it's going to show a tinge in the CSF. The CSF is very clear. If somebody saw CSF before, it's very clear fluid. But if you see a CSF which is yellowish or has got an orange yellow tinge, then this is more likely to be a dansochromia. And you would get increased RBCs in the microscopy as well. If you see blood coming out, this is not from the subarachnoid hemorrhage. This is what we call a traumatic tap. This is from the needle itself. It's likely caught of a small vein or so as you were putting the needle in the patient's back. So blood on its own, it doesn't mean a subarachnoid hemorrhage at all. The change of the color, the xanthochromia, and the RBCs will point towards the subarachnoid hemorrhage. Fine, your final patient, you are nearly at the end of the shift now. 22-year-old male, he's unwell. He self-presented to the minors. He has been having sore throat for the last 6 days, fever, headache. His Nih score is 11. A Nih score is a score we use at the triage. It's called National Early Warning Score. It's used everywhere in the hospital, actually. It's basically to quantify how unwell the patients are. 11 is too high. 11 means that the patient is in a critical condition. Ideally, they should be like in resus or one of the majors cubicle. But because everywhere is busy, the consultant was happy for you to go quickly and have a quick look on the patient, gather some history, examination, and come back to them. And he was going to see the patient himself. The patient is COVID negative. He had a rapid antigen test at the triage, so you don't need to worry about COVID now. The heart rate is tachycardic, his blood pressure, that's how the Nih score is formed. 11 is too high, and it's formed from all of these actually. He's confused, pyrexic, tachypneic, tachycardic, and hypotensive. So on assessment, A to E assessment, the airway is patent and clear. Breathing, respiratory rate 24, as we mentioned. SATs are fine on the room air at the moment. Bilateral equal air entry on auscultation, and the chest expansion is fine. His capillary fill time is less than 2 seconds, and the heart rate 124, blood pressure, as we mentioned, 92/51. GCS is just 14, losing 1 for the verbal. He's confused, and you know now that blood glucose can cause confusion, so you asked for it yourself. And they told you that it's normal, so you don't need to worry about hypoglycemia. Pupils are equal and reactive to light, and they are 3 millimeters. On examination, however, you can see a non-blanching rash, and there is neck tenderness on palpation, and the temperature is 40. So this is what you see in examination. This is called a glass test. The reason they use the glass, because when you put pressure on the skin, ideally any viral rash should blanch for a second or two, and then it would come back. But in this case, as they put the glass on, the rash does not blanch, and this is really concerning. Any idea when you would see this rash?
In viral meningitis?
Yes, you can see it with viral or bacterial meningitis. That's correct. Particularly meningococcemia, severe meningitis. It's now septicemia. Perfect, that's correct, Selena. Fine, we are nearly there. It's all done now. So the last question, what would be the next steps in management? Okay, all of them are right answers. So as we mentioned, we are suspecting meningitis, meningococcemia. In this case, we don't know whether it's bacterial or viral. So in this case, we give broad spectrum antibiotics plus or minus antiviral. It all depends on the local policy. Usually what's given is ceftriaxone or ceftriaxone, whichever way you pronounce it, and acyclovir. Acyclovir would cover against herpes simplex, encephalitis, and meningitis. However, it doesn't cover against all the viral infections, like let's say Epstein-Barr virus. Infectious mononucleosis can give encephalitis and meningitis. Acyclovir is not particularly effective against it. However, it helps with it if it was EPV induced. ITU involvement, definitely I will, because in this particular case, his blood pressure is borderline. We're not entirely sure whether he would respond to the initial fluid resuscitation or not. And he's having meningococcemia, septicemia. If the blood pressure does not improve, then this is septic shock. This patient, ITU team should be aware of their presence because they are likely to deteriorate. They don't need to take them straight away. He can stay under medics, but their involvement can be imminent at one point. Sepsis 6, yes. Do we know what are sepsis 6? Okay, so sepsis 6 is a collective term. It's for everyone. It's to simplify how to treat sepsis for every part of the medical team. So in sepsis 6, you take 3 and you give 3. What you take from the patient is you take cultures, you take lactate, which is part of the VBG, because lactate, if the patient's having a high lactate, this means that they are having more sepsis. And you take urine output, you need to measure the urine output because this will tell you how shocked the patients are. Because if the patient is really shocked and they went into renal shutdown, the kidneys are completely shut down, they would have no urine output or minimal urine output. That's why you need to take the 3 blood cultures, ideally before giving any antibiotics, because you will do culture and sensitivity on these, and then you will find out which antibiotic is more effective. And that's what you take. And what you give is you give oxygen, maintain the SATs between 94 and 98. For this patient, despite the fact that the SATs are 96, I'd still put some oxygen on. They are very unwell. I'd keep the SATs at 98. Give IV fluids. You need to resuscitate them. So you can give like boluses of 500 mils. You can give 2 boluses and see whether they would respond to fluids or not. But after 2 liters, if it's not touching the patient, if the lactate is still high, and if the blood pressure is still that low, this point, ITU will need to come down and take the patient, give vasopressors and so on. And give antibiotics, which we just mentioned, antimicrobials. This is the correct term to use, which covers antibiotics and antivirals or antifungals, if it was the case. So sepsis 6, you need to be aware of its presence. Everyone knows in the hospital, should know actually what's sepsis 6. And we do regular national and local audits to find out how compliant we are with the sepsis 6. They should be done straight away, very quickly, fluids and antibiotics within 1 hour and so on, 1 hour. And finally, consider non-enhanced CT brain. It's not necessary to be done straight away, but to be considered. There is it's controversial. Some sources say you can wait. Other sources advise to do it as urgent and as early as possible to rule out any space occupying lesion or any increased intracranial pressure before you do a lumbar puncture, because again, you would need to do a lumbar puncture at one point. Other sources would just say to delay it or postpone it. It's not as necessary as the other stuff. But again, it should be part of your plan when you write the plan down in the notes. Fine, so the consultant takes over this patient. He gets in touch with the ITU and the patient gets admitted in the ITU. You did the right job. And your shift finally came to an end. Now it's time for the handover. The consultant asked you to attend, and afterwards, everyone was very pleased and thanked you for your performance, especially it was your first shift. You didn't have a formal induction. The consultant now is just asking you to come up with one single take-home message from your night shift. It's basically one medical piece of knowledge that you didn't know before. and one technical skill that you acquired tonight. So I just need each one of you to tell me something new that they came out with from this session.
Okay, so we haven't done pediatrics. I'm a fourth year medical student, and I did not know that there was a child GCS and there was an adult GCS. I didn't know they were separate things.
All right, that's good. What other technical take-home message? By technical, we mean any part of the communication with other teams or any part of managing your own pace among a very chaotic place or something like that.
Don't always rely on the stroke team in case they really are busy.
Okay, fine. Fair enough. Tina?
Well, I agree with the person who just talked, and also it was nice to remind that we need to talk with the child, like about what happened with the technical thing.
Yeah.
And the medical, I think it was really useful. Like the Andexanet alpha, it's really new to me, and now I will be know about it.
All right, perfect. Thank you, Tina. Mustafa?
I think it's the point that in the ED that you need to consider your time limits as well, because you have only about 4 hours. So you need to make decisions based on that and how to quickly get a form of diagnosis. And on a medical note, I think some of the scores that you went through, like the Rosier's score for the stroke in the ED, and even the Sepsis 6 that we just did as well. So,
Yes. Perfect. Thank you, Mustafa.
thank you very much.
No worries, you're welcome. Syrian? And IPEC? Okay, fine. Does anyone have any questions? I know it has been a very long session, but I just tried to cover as much as I can of the common presentations. Has anyone got any questions at the moment? Fine, so thank you all. Just a bit of a quote that I really like, just as you work in A&E, just be comfortable being uncomfortable. It's a very uncomfortable environment for everyone. But once you get used to it, just try to find your own pace and your own peace of mind among all that chaos, and just be organized in your thinking. That would really help. And good luck for everyone. Thank you all for attending, and thank you, Selina, for organizing all of that.
Thank you very much, Doctor. Very good presentation.
Thank you, Mustafa. And just feel free to write in your feedback how we can make the presentation better, please.
Will do. Thank you.
Thank you so much, guys, for attending. Thank you, Mr. Masaryk. That was a wonderful presentation. It was very interactive. Just before you all go, please all put in some feedback. It's the links in the chat, and I'll also be sharing my screen as well in order to get a QR code. Thank you all, and have a nice evening.